I'm Amy Shivers. I'm the Director of Events at Crain Chicago Business. On behalf of Crain's and our sponsors, it's a pleasure to welcome you to our 4th annual Physicians Breakfast, part of our Crain's Executive Healthcare Event Series. During today's presentation, we will discuss macro trends that physicians will encounter and in which they may need to participate, including the changes physicians face in the new legislation and navigating the consolidation that is happening in healthcare. I'd like to introduce the sponsors who are here to support you in this journey. These Chicago area businesses have placed a special emphasis on serving the healthcare industry. When I say your name, please stand so we can recognize you. From our first co-sponsor, Humana, we have Dr. Neil Fisher. He serves as Senior Clinical Officer for the Medicare Advantage program in the Great Lakes region. Humana is a leading healthcare company that offers a wide range of insurance products and health and wellness services, which take an integrative approach to lifelong well-being. In Illinois, Humana offers Medicare and commercial and individual health benefit plans to its members. Thank you for being with us, Neil. Our next co-sponsor is Hired My Way. Representing the company today is Alexandra Figley, Director of Sales. Through dozens of partnerships with the top job boards, social media sites, universities, and traditional media outlets, Hired My Way gives employers access to many job sites from one easy-to-use dashboard. This approach allows organizations to reach a much larger but more targeted audience. Hired My Way also provides recommendations on the best places to post a position based on current job seeker trends. And as people apply, its filtering system identifies serious and qualified candidates. Thank you for your support today, Alexandra. Our third co-sponsor is Loyola's Quinlan School of Business and its Executive MBA Healthcare Management Program. Joining us is Pamela McCoy, who is the Assistant Dean of Executive Degree Programs. The Quinlan School is a nationally recognized leader in graduate business education. Its Jesuit tradition, which focuses on ethics and social responsibility, guides the school's overarching principles that doing good is good for business. Quinlan's MBA Healthcare Management Program is designed for professionals who understand the importance of sound business practices in healthcare. Senior leadership needs to have talented professionals in their organization who are ready to manage and lead critical initiatives. Developing these people is the mission of Quinlan's MBA Healthcare Management Program. We are glad you could join us, Pamela. And now from our presenting sponsor, Comcast Business, we have Kevin Burnson, who is Senior Manager of Enterprise Sales. Comcast Business Ethernet can help improve the quality of care of your organization. With speeds up to 10 gigabytes per second, you can make telehealth from multiple locations a reality. And the solution is flexible and scalable, so it can grow along with you while keeping costs in line. Kevin has more than 15 years of experience in telecommunication and data networking industry. He is responsible for expanding sales of Metro Ethernet and advanced technology in the Chicago region. Kevin's specific focus is on healthcare, government, and education. This means he leads Comcast's largest market for the country in these niches. Please join me in welcoming Kevin to the podium to share a few thoughts.
Good morning. Thank you very much for the great introduction. It's a pleasure to be here today as a presenting sponsor for Comcast Business Services. Comcast offers a true alternative to the phone company, offering local, long distance, and data communication services for anywhere from 10 megabits up to 10 gigabits to help the healthcare industry deal with the ongoing demand for bandwidth services. It's a pleasure to be here today. Enjoy the breakfast and enjoy our speakers. We have a great topic to cover today. Thank you.
Thanks, Kevin. I'd also like to quickly acknowledge a few of my colleagues who are here from Crain Chicago Business. First, we have our editor, Michael Arndt. He will be introducing the moderator for today's program. Next, we have Assistant Managing Editor Tom Korfman, who directs Crain's expanded healthcare coverage in print and online. His team of reporters, Andrew Wong and Kristen Schorsch, are also here today. Please join me in a round of applause for this editorial team and their contributions to Crain's. In addition to our local business coverage, Crain's has a free online resource, chicagohealthcaredaily.com. It offers breaking local healthcare news and in-depth analysis, which is served up daily and weekly. We also have Chicago Healthcare Daily email newsletter, which delivers essential news to your inbox. I invite you to visit chicagohealthcaredaily.com to begin receiving additional insights into the field and the local market. I know you're eager to dig into this morning's topic, so let's just get on with it. I'm happy to invite Mark Arndt to the stage to introduce our moderator.
Thanks, Amy. Good morning. We could not have a better person to lead this morning's discussion than Dr. Joel Shalowitz. I have to say he makes me feel like a complete slacker. You'll see why. He is a clinical professor and director of the Health Industry Management Program at Northwestern University's Kellogg School of Management. In addition, he is professor of preventive medicine at Northwestern's Feinberg Medical School. If that's not enough, he is a visiting professor of health industry management for Schulich School of Business at York University in Toronto, and he's a director of Novadeck Technologies. Joel practiced internal medicine for 24 years and is still managing partner of a primary care group of 20 physicians he co-founded in the north and northwest suburbs in 1983. He is a diplomat of the American Board of Internal Medicine and a fellow of the American College of Physicians. He holds undergraduate and medical degrees from Brown University, my daughter's alma mater, and he earned his MBA from the Kellogg School. Joel has received 3 Fulbright Awards, and in 2012 he became Senior Fellow of the Research Institute of the Finnish Economy. He also has co-authored 2 books. Please join me in welcoming Dr. Joel Shalowitz.
Thank you. Welcome, everybody. I love this opportunity because I get to see a lot of people I haven't seen in years. I won't say old friends because that has a bad implication, but if you're out there and I haven't seen you, come up and say hello afterwards because this is sort of like a family reunion. Also some old friends on the panel as well. So what we're going to do right now is have each of the panelists briefly introduce themselves and give you an idea of their areas of expertise. And then we're going to jump into some questions. And after those questions, seeing how much time, we can open it up to some of the questions that you've submitted in advance and then open it up to everybody. And that should hopefully take us to the end, and afterwards maybe the fog will clear and we can enjoy the beautiful view up here. So thanks again to Crain's for sponsoring this. So let's start closest with Steve. Introduce yourself, and that was a way long introduction of myself. I'm surprised they didn't give me my grandmother's maiden name, but we don't want that. All the bios you have in the packet, and so I want to spend the most time possible on asking and answering questions. So, Steve?
I am a general internist here in Chicago in private practice. I started with Northwestern in 1993 after my chief residency year. Throughout the 1990 and early 2000s, my practice was 30% hospital-based medicine, including critical care, and 70% outpatient medicine, and that consisted of about 100 to 120 office visits on a weekly basis. My area of expertise is in managing complex medical patients and difficult diagnostic issues, But my passion is truly treating the whole patient, understanding that that patient has a life history. You know, following evidence-based medicine and the scientific method, but being ready to adapt to the particular patient's needs, the diagnostic or the therapeutic algorithms. So I look forward to today's discussion as to how we're going to best be able to do that in the future.
Thank you. Abel.
Yeah, hi, good morning. My name's Abel Coe. I'm an internist and also a researcher over at Northwestern University's Feinberg School of Medicine. I trained in medical informatics before coming back to Chicago. I'm actually a local guy. My area of expertise primarily has been around health information technology, so implementing EHRs and clinical practices. Over the past 3 years, I've been the co-director of the Chicago Health IT Regional Extension Center, which has been funded by the government to essentially install electronic health records and primary care practices throughout the city and help them achieve meaningful use.
So by the way, if you were in the 606 zip code and want to implement EMR, everybody call Abel today. All at once.
Hi, I'm Barbara Loeb. I'm also an internist. Internist times 3. I practiced internal medicine in my own independent practice in Downers Grove in the advocate system, so Lee and I are pretty good friends. About a year ago, I left my internal medicine practice and joined Presence Health as the CMO of Resurrection Medical Center. And more recently, I transitioned to be the medical director and the CMO of Presence Health Partners, which is our a vehicle under which clinical integration, our ACO operations, and all our contracting that will pertain to the new models of care will be rendered. I have a lot of areas of expertise, but a few that I think are very apropos to today and what's happening in healthcare are my interest in performance improvement. Presence Health, I don't know how many people know, Presence Health is the merger of Resurrection Healthcare and Prevena Health. We have 12 acute care and one LTAC hospital in Chicago area. And we are embarking on a lean journey we call breakthrough improvement. And so I've been very intrigued on how to eliminate waste from the system, because as we know, we have to improve performance with less in this new age. So I'm very interested in what we've done within Presence. I'm also very interested in clinical transformation, transforming the way we deliver care, which includes our population management, patient-centered medical home and care management. And those are the areas I'm very highly involved with in my new role in Presence Health Partners. So thank you.
Good morning, I'm Lee Sachs. I'm a family physician. I practiced 13 years in a 2- and 3-person practice in the northwest suburbs. And since 1995, I've been involved in Advocate's executive management team, serving as the CEO of Advocate Physician Partners and the chief medical officer of the system. If I had to describe my expertise or area of focus, it's on quality and safety, as well as the efficiency of care in our clinical integration program. So I look forward to the conversation.
Okay, thanks, Lee. So why don't we get into some of the questions? We'll start with Steve. So you've started a concierge type practice. When did you start that? How long ago?
Initially, I started it in 2000. I had about 4,300 patients at the time, and I opened a pilot program, and I had 100 patients sign up. It was a struggle initially because you always want to make sure that everybody is getting proper medical care. But the way that I kind of put it forward was, it's like an airplane. People fly first class and coach. Everybody has the same pilot and the same mechanic. But the people in first class get to get their appointment when they want their appointment. The ease at getting back to them is a bit easier. So that initially started in 2000. People then started asking me if they could join the program. So I eventually then converted 100% in 2006. I brought another internist on that continued to take insurance so that those patients had care. About 20 to 25% of my care is free pro bono, and then the rest is kind of a retainer and fee for service. I'm out of all insurances. I don't take Medicare, and I basically know my patients pretty well and see who can afford it and who can't afford it, and it works pretty well. You're all business people, and it allows the free market to do its magic.
Yeah. So you said that you were seeing about 100, 120 patients a week before.
Right.
So how many are you seeing
Right.
now?
So I would see at that time between 20 and 30 patients 5 days a week.
Right.
Now I see between 10 and 15. So what that allows, it not only allows me to provide a little more care for the patient, again, since this is a business conference, what it allows me to do is kind of educate the patients as to why they don't need a particular test. When I was seeing 30 patients a day, people would come in, and the easiest thing to do is to order a test to kind of finish with that patient. It takes time to explain to the patient why you don't need an MRI or why you don't need a CT scan, and you need to develop that rapport. So the new system, my change in my system, I should say, allows me to be able to educate my patient and work with my patient and really understand them.
Great. So we know there are a lot of big national companies, and I probably shouldn't name any of them because that would be an advertisement. So what made you decide to go it alone versus going with one of the big national companies that do concierge medicine?
I work for my patient. So what I tell my patients is that when they come into the office to see me, I'm their employee. So I want to always be able to focus on giving the best advice for that particular patient. I don't want to work for a big organization that tells me how I have to treat my patient. Now, I understand the need for systems and the importance of kind of getting as many people covered as possible, but my job and my role has always been my patient. So I work for them. I don't work for a big national company, and their interest is always first. I've been on staff at Northwestern really since 1989 when I started my residency there, but I'm loyal to my patients, not the brick and mortar. If I think a patient could get better care at the University of Chicago or at Rush or at Lutheran General, then that's what I do. I refer the patient there and I follow them there. So to answer the question, I intend to remain independent until the government tries to squeeze me.
So if you had any advice for somebody who wanted to do that, not just positive advice, but maybe pitfalls, that mistakes you made that you'd advise somebody to avoid or how to avoid, what would that be?
Yeah, I would think that the number one thing that physicians need to do with their patients, not only from a healthcare standpoint, but from every aspect, is communication. So let the patients know why you're doing what you're doing, what you're planning on doing. Let them understand why you're doing that, and just be clear. And the best teacher is redundancy. So the more redundant you are, I think the best the patients will understand that. So I guess my advice to any physicians that would be, considering that is explain your reasons why, and then explain it 2 more times, and patients, then will hopefully understand it, and you guys will have that open lines of communication.
Okay. So one of the things that I hear going on out in the world is that with the ACA, and we'll deal with this issue a little bit later also with other people, is that people are really afraid that the shortage of physicians, particularly primary care doctors, particularly internists, is getting worse. Do you see a lot of people wanting to sign up with your practice to buy futures in access? Does that seem to be something that you see in your patients?
No, you're exactly right. So what's happening is I've had a waiting list for probably the last 5 years, and I continue to try to add patients, but you don't want the practice to expand too much, because then you'll get back to the same situation. You'll be making more money, but you'll be back in the same situation with difficulty managing the patients. I do agree with you. I think there's going to be a major supply problem in internal medicine. When I did my residency, and right after my chief residency, 30% of my class went in internal medicine. Now I think it's 3 to 5%. Abe or somebody would probably be able to better speak on that. Maybe. So you have less people going into primary care, and you're going to have a large influx of patients appropriately. I mean, those patients need to have care. They need to have coverage. But I think, again, people in the business community have to figure out a way to have everybody have some skin in the game. So once that coverage goes forth, people have to have some responsibility for their own health care, or be made aware of that.
Okay, thank you. Let's move on to Abel. You're on the hot seat. Okay. So one of the things that Crain's has done a very nice job is to follow the whole information technology situation in Chicago. And in April of 2011, Crain's reported about the Metropolitan Chicago Healthcare Council forming this large healthcare information network. And then on Christmas Eve, where's Kristen? Kristen, you're here. Oh, there you. Okay, hi. You reported the demise of that network. This, it was a good Christmas present for everybody in that industry in Chicago. But some people said, it was sort of inevitable for all the reasons that health enterprise networks and RIOs failed. All right, so the tough question is, what's different this time other than upfront government funding? Why do we have any reason to believe that these HIEs are going to be here?
Yeah, HIEs are a challenging space, as you've known, and over the past 20 years, people have tried to stand up these health information exchanges multiple times, and they've oftentimes failed. I think you do see some successes out there, and I think everyone recognizes that there's value to it. I think at the end of the day, people see that there's value to the patient and being able to have your information wherever you go to receive care. But unfortunately, at the more micro level, at the institutional or individual provider level, it's harder to make that argument, because oftentimes there's an upfront cost, there's some benefits, but they may not directly accrue to you. They might benefit somebody downstream from you. So there's a lot of misalignment right now in the current HIE models. Now, the people at MCHC have done a great job. I think that there's a very thoughtful group there, and they've done the best that they can given the market that we have. But you need to have a couple of neat things in place. You need to have, obviously, a certain penetrance of health information technology. You have to have EHRs in place. I think you have to have partners that are willing to fund this upfront, and you're also going to have to find ways to demonstrate the return on investment. And a lot of those pieces may not be there or may not have been there. But I think that we're in a different time now. So we've got a rather unusual alignment now of both government, vendor initiatives, and also patient awareness, which I think suggests to me that this time might be different. In other words, if you look at sort of the government initiatives, they've obviously had the Meaningful Use Initiative, and interoperability is part of that. But you've got people like, for example, on the Democratic side, the national coordinator saying we've got to get away from walled gardens or silos of care. And you also have Republicans saying the same thing. So Republicans actually were critical of the current rollout of health IT, saying that it hadn't gone far enough, that there wasn't enough interoperability. So that was both sides saying essentially the same thing, that we needed to find ways to interoperate. On the vendor side, we've seen initiatives coming. I think there was an announcement recently at HIMSS about some of the larger vendors getting together and saying, we're going to make interoperability a priority. We're not going to make this something that you have to go out and buy from other vendors. You're going to go ahead and it'll be a feature. It'll be there. It'll be in place for you, which I think makes a lot of sense. I was actually just in South Carolina, and you'll be able to rent a car. We had our child seat with us. And the irony of it all is that you can go and take a child seat and be confident you can go anywhere in the country, and there's going to be a latch system. You can latch that car seat in place. It's going to interoperate. But you go and take that person that is inside the car seat, and you can go to any emergency department around the country, and you're pretty confident that they're not going to be able to interoperate. So it's a really strange emphasis we have on why, why is the car seat more important than the person inside it? But I think that piece, I think, gets that last and most important part involved, which is the patient. And I think patients now, I think more and more are expecting that you will be able to get your records from anywhere. So there's initiatives like Blue Button, the VA Blue Button initiative, where vets can go ahead and download their records and bring them with you wherever you want to go. You've got New York City, who's got a patient portal available to anybody. You can go ahead and sign on. You can get information about yourself from the Health Information Exchange, which has been operational for a while. That kind of empowerment, it's hard to push back. Once you open that Pandora's box, you can't tell patients they can't have it anymore. So you've got this interesting confluence now of government initiatives. You've got vendors which are saying, we're going to go ahead and do this because it's the right thing. And frankly, it's going to be good business practice down the line. And then you've got the patients saying, we're not going to be pushed back. We're going to get our own information. And once you have patients who are able to access their own information and become that unit of transmission of their own data back and forth, a lot of these issues go away. I think, and a lot of the costs that have made HIE so difficult to implement, those agreements that have to go in place, the strong funder, the person that brings the community together, that becomes less of an issue. And I think that makes an ROI a lot easier to realize when the costs to invest go go down a lot. So I think that we're in a different time. Hopefully it's going to...
Let me ask you a tough question that
Sure.
I think may be on other people's minds here.
Yeah.
Are some of the closed systems going to be joining this consortium for interoperability?
Yeah.
I'm thinking of a particular one in Wisconsin that people
No,
again, without mentioning any particular name.
Yeah, I think the quote was that they weren't invited. But I think that was...
Well, that's what she says.
That's what she said. But the reality is that people have looked at this consortial sort of agreement as one of two things. Either it's bluster, or maybe it's really just a chance to sort of pool together to sort of take on the real sort of gorilla in the room. But I think again, people do see the writing on the wall. The vendors recognize this, and having been involved in a number of health information exchanges and doing it in other cities, the kind of work it involves, the technical work actually is not all that difficult, but it does involve a lot of political will, I think community initiative. That part is harder, but if the technology is there, the platform to make it easily done, I think then these walls start coming down, and I think that's really kind of where it needs to go. I don't think that you can. Interoperability is not one monolithic system. We're not going to have Windows for everybody. It doesn't work. I mean, I think that's a market that is ripe for somebody to come in and blow it up. And I think that's where we're at the cusp of right now. Probably next couple of years we'll see that happen.
Thank you. Yeah. That's great. Barb? Hi.
Hello.
So it was really hard coming up with questions for you because of all the things that you've done, all the very different kinds of areas of expertise. But being in this position, I get to pick the question, right? So, and it helps me out. So one of the things, the ACA is the gift that keeps on giving, right? So you keep reading it, you keep finding new kinds of things. And one of the things while reading it again and again that I found was that hospitals are now being required to do community-wide assessments and implement plans that HHS is going to review every 3 years. And if you don't do this and they don't like it, you can lose your 501c3 status. That obviously involves a lot of people at the hospital. This is a physician's breakfast, so I'm aware that physicians are involved. So what's your organization? I know your organization is doing a lot, so this is the question. What are you doing? How are you doing it? Problems, successes?
Well, I'm really glad you asked me that question, Joel, because actually I'm really happy to share that we've actually done it throughout our whole system already. So we've done the first part of this, which is actually doing the assessment. And we did it in collaboration with IPHI, which is the Illinois Public Health Institute. And they helped us get the playbook together on how to do it. And we brought together, we already had neighbor relationship councils. So we had, in many of our communities, already a relationship with the people in the community. So we were able to build off of that, get local government folks, local clergy, and get together and create steering committees at each one of our hospitals and really dig deep into the data that was available, demographics, et cetera, and then also do focus groups and take surveys from patients. And we rolled it all up, and we actually found out what some of the great needs are throughout our system. And they're not surprising. We found out chronic disease, the diagnosis and treatment of chronic disease was really big. Access, which I'm all sure that all of you have struggled with that. Access to care and navigation of care was also big. And of course, mental health and substance abuse care and where you can get that. Those were the top three biggies. And so we're now in the second phase, which is the action planning phase, and we've created some subcommittees that are focusing on each one of those areas. We have like a nutrition and health committee that also does education, looking at access to food and education on nutrition. We have a chronic disease committee, mental health and behavioral health committee, and also a committee that works on access. So we're in the next phase where we're getting the resources evaluated that are already in the community and making those resources available and sharing that throughout other places. Because as you know, even though healthcare organizations have to be an integral part of this, it's really a community needs assessment, so it has to go out into the community. If it stays with President's Health, it won't be successful. And really the best part of all of this is, as we're going into population management, we need to know what the population needs. Because if we don't know what the population needs, we're going to be doing a treatment plan that may not be the right treatment plan. So we'll be maybe sending care managers out all over the service area. Maybe care management is not what the patients need. Maybe they need education. Maybe they need food. Maybe they need a ride to the doctor. So I think although it feels like a heavy government burden to have to do this. I think it's really the right thing to do, because unless we customize what we deliver to our patients and our communities, we're just going to go bankrupt trying to deliver the wrong thing. So I'm really happy that we're ahead of the game on that.
So I guess I know the answer to this, but has it been easier working for a faith-based organization? The answer is probably yes, but do you notice a difference if maybe you worked for a for-profit?
Well, I never really worked for for-profit other than my own practice, but Advocate also is faith-based, not just a Catholic system. But what we had very strong within our Catholic system, of course, a very strong value of charity, and we had very strong parish nurse programs. And the parish nurse program throughout Resurrection Healthcare and Provena Healthcare, that has been a great starter, because we have nurses that are out in many parishes already looking at the community needs, are already resources and navigators. So building on a parish nurse program has been one of the added extras of being part of a Catholic health system.
Great, thank you.
Thanks.
Lee and I have known each other for more than half of our lives, and I won't tell you how many years that is. So it's always great to see him. Again, Lee is also, among the others, very multi-talented with a lot of different skills. So again, it was hard to figure this one out. But one of the big areas right now is antitrust, and it always sort of puzzled me why the government is working at cross purposes. So, on one hand, the government wants ACO formations, and on the other, it's beefing up its antitrust activities like never before. So the question is, as people go down this road of consolidation, as Advocate has and Advocate Physician Partners, what are some of the pitfalls, advice you can give to avoid running into antitrust problems? And I know that you're going to meet with one of my colleagues in the next week, who's an economist working for the Fed.
Okay, well, first disclaimer, I'm not an attorney. I've spent far too much time in the last decade with attorneys and regulators, et cetera, so I've sort of become a self-taught expert. I think the key value, or the key word is value, that if an organization is delivering value for its constituents, there's a lot more leeway in terms of the regulators. And in the time that we've been under the scrutiny of the Federal Trade Commission, I think they've become much more enlightened to appreciate that it truly takes a team to organize healthcare, and especially to manage chronic disease and illness burden where tremendous cost opportunities are. Clinical integration might be the most overused phrase right now. It's a regulatory phrase that is a safe harbor for the Federal Trade Commission. It's a catch-all phrase about where the delivery system needs to go. But the way we define clinical integration is that it's an ongoing structured collaboration between and among physicians and hospitals that's designed to improve the quality and efficiency of care. And in order to do that, we've come to appreciate that we have a shared governance model. Governance is shared between physicians and the system. We've created infrastructure. The so-called secret sauce, in the 2 election campaigns, the president rattled off 5 healthcare organizations that he holds out is the mecca of where the country needs to go. And let's see if I can get them right. It's Kaiser, Intermountain, Geisinger, Mayo, and Cleveland Clinic. And all of those are group practice model, to Intermountain to a lesser extent, but the other 4 are completely with that. And what I've taken to say is that our 3,000 independent physicians can perform like those models because of the infrastructure that we provide them. A lot of respect for what Steve is doing, but I'd hasten to say he probably doesn't have the same infrastructure that a large group practice has, whether it's information technology, whether it's training and development. As I said, I was in a 3-person practice. We didn't have a human resources department. We didn't do screening for employees and training and things like that. So we've helped our physicians to position themselves with the infrastructure. We have pay-for-performance incentives, and I'll be the first to say that today's fee-for-service system is part of the problem with conflicting incentives, but you have to work with what you have, and in the fee-for-service system we have pay-for-performance incentives that sharpen the focus and help reward physicians for things that don't get paid for in the traditional system. There aren't codes for it, so you can't spend the extra 30 minutes educating a patient of why they don't need an MRI of their knee and that there's a better treatment plan. And then we have data transparency. We collect all kinds of metrics that are related to quality, efficiency, and safety. And today, across our network, all of our physicians can look at the results of any of their colleagues. It creates incredible peer pressure. It also allows physicians to use data to decide where they want to refer their patients with that. And then this is an endless feedback loop. It's a process that's improved over the 10 years, and there's no question we have to get even better if we're going to continue to create the value in the new paradigm with the Affordable Care Act, insurance exchanges, et cetera. So hopefully I touched on what you were looking for.
Yeah, just, well, one or two follow-up questions, though, obviously. So some of the groups that you mentioned, Geisinger, Mayo, Cleveland, said thanks but no thanks. We're not going to be part of the ACOs. We're not even going to be part of the pioneer ACOs. This was a lot of groups like that through the American Group Practice Association. I know that you, advocate, are part of an ACO and also working on a private with Blue Cross. Do you really need the pressure from the government to get it done, or could you just do what you want on your own and get it accomplished? I mean, what does other than patience, of course, what does that give you?
Well, as Joel said, we started with a commercial ACO, Accountable Care Organization, for lack of a better term, with Blue Cross of Illinois, and it really grew out of both Advocate and Blue Cross sitting down and saying, if we keep doing things the old way, it's a tug of war. There's a fixed pie of dollars, and I can tug hard one year and they can tug hard the other year, but that really doesn't create the alignment. And any of you who are on the provider side or the payer side understand when I say that there isn't good alignment between the payers and the physicians in the hospital. Sometimes you have physicians in hospitals going in different directions. Other times you have the payer or the employer going in one direction and the physicians in the hospital doing something different. So we came together and said, how do we create better alignment? It's not perfect, but the idea being that as we improve quality and service and take costs out of the delivery system, some of that comes back to our organization, because otherwise you're just taking out top-line revenue, and that's not a long-term success in any business that needs to reinvest and that's capital intensive. And that was ahead of the federal program. And before the rules were made. The interesting thing was we had an 11-page letter of intent. When the Medicare ACO rules came out, it was over 600 pages. The regulators thought they could anticipate every possibility and put it all in detailed regulations. We were smart enough to know we couldn't anticipate everything, and we'd have to make mid-course corrections, and we continue to do that in real time as we figure it out and work to create better alignment and improve the system. So fast forward, we chose not to participate in the Pioneer ACO. We were offered the opportunity, and we felt that it wasn't thought through enough. The time frame was too short, and it was fraught with problems. But we did choose to participate in the second cohort of the Medicare Shared Savings Program, which began last July. And I think we have the largest cohort in the country. We have 119,000 attributed beneficiaries. One of the real benefits to us is that that got us past the tipping point. As large as Blue Cross is in this market, most of our practices don't have enough attributed Blue Cross patients to really change the way they approach things and look at it in terms of population management. Is we've tried to create what people commonly described as a patient-centered medical home with embedded care managers. If you don't have a critical mass to support a care manager, you end up doing it part-time, and then the care manager's not there when Mrs. Jones, who really needs it, shows up, or you do it on the telephone. And I think we all know that the data says telephonic care management creates minimal value, if any. So adding the Medicare cohort got almost all of our practices past that tipping point, and has everybody focused on managing all their patients in the new paradigm of population management and value creation. I kind of look at it as a, don't quote me outside the room, as a loss leader. If we just break even on that, it will have furthered the journey to transform our organization into one that does population health.
Thanks. Okay. So that's the introduction. Now we get to some of the meatier issues. Not that they weren't. So on the heels of Lee, I just want to open this up to everybody. And one of the issues of accountable care organizations is that we're making organizations responsible for both the cost and quality of care across the continuum. And yet, as you know, the government says, well, we'd love to do that, and we're going to make you financially responsible, but we're going to give the opportunity to patients to go wherever they want to go. And this is sort of a business conference, right? So I thought that you're never supposed to be held responsible for things over which you have no control, but I guess it's the government. They can do whatever they want, right? So what about this open model, freedom of choice, that even seems to be driving our U.S. healthcare system with respect to insurance? Can we really maintain that and expect to reduce costs? So let's start maybe with Steve.
I mean, I think it's obviously to be difficult, and I agree with everything Lee said, but I do have the best typewriter in town, so. You have to have some responsibility. The patients have to have some responsibility. I mean, again, we work for the patients. One of the interesting things that I heard everybody mention is the provider, the payer, and the provider, and I keep hearing that the patient isn't in the mix. So I think patients have to be put in the mix in some way, and we need this kind of interaction from both ends of the spectrum. I do think patients need their freedom to choose the doctor that they want to go to, but then they need to pay for that to a certain degree, to the level that they can afford it. Doctors in general historically have been very charitable, and I would never turn a patient away that couldn't afford it. I would make sure that that patient had access to care. On the same token, patients that have $1 billion shouldn't be getting paid, I shouldn't be getting paid $60 for the office visit. So I think there is some give there. What other organization or what other business allows an outside person to determine what your cost is? The best cardiac surgeon in the country gets paid the same as the worst cardiac surgeon in the country for a bypass surgery. That just doesn't work in a capitalistic system. There's a lot of incentives to drive medicine away from being a profession and a caring service to a business. And my role, I see, is kind of trying to pull it back to patient care and the person connection.
Thanks. Now, the spin I want you able to take on this, because it maybe not quite up your alley, is are we ever going to see the individual patient unique identifier?
Probably not. I think that's been tried a couple times. But having said that, you don't necessarily need to have one identifier for the person, but you do need to have technology that allows you to reconcile that identity wherever they go. And that technology already exists. It's not like when you go check in at a hotel somewhere and you have people, you can find the records. You can give them your, some identifier, and they can look you up or create a new record. That's not a problem. So I don't see that necessarily holding us up. I was going to add to this, though. I do think this whole ACO insurance model is a little bit at conflict, at odds. You have, in one sense, this drive and push for groups to consolidate. And one thing we've seen around Chicago is that there's been this tremendous consolidation in the system, and a lot of small practice and providers saying that we need to get out because it's just there's all these onerous burdens on us. How do we manage? But it seems like there could be a solution somewhere in the middle. I mean, if some of the infrastructure, these things that we refer to, were made available to the smaller practice, I think that you could empower. You can imagine a day when a smaller practice would be empowered to have all the infrastructure, all the capabilities, the care management tools, the data management tools that a larger system could have. I think a lot of providers would appreciate that. I know certainly ones we've heard would say that'd be a great thing, and they would leap at that chance. And that isn't. I think it's not necessarily a bad thing. I think that's one way you could sort of have both choice, and instead of having large systems where people have just choice between systems, you could actually really choose wherever you wanted to go if you had that individual level patient sort of focused data.
Thanks. Barb?
Well, I think actually both Advocate as well as Presence Health have made a lot of those tools available to small practices. I myself actually practiced in Advocate for all my career, and we were able, excuse me, to make the tools to have these resources available for small practices, to answer your question. And also Presence Health, we have the same pluralistic model. So practices can use those tools. Back to Joel's original question about the patients and freedom of choice. I mean, there's two ways to look at it. One is, obviously, if you deliver highly effective care and patients are very aligned with the practice that they're in, they'll follow the recommendations of their physician. My patients would ask me where to go and what to do, and they had confidence that I would direct them. I didn't see them running off to places all over the country and the city to get their care. So I mean, it's as good as we are, as close as we can keep them will be determined on how good we are. The other thing that I see as a possible factor in that is, as we have the health exchanges and more people are purchasing their insurance, this insurance will have customization that drives patient participation. So there'll probably be different models of insurance. Just foresee some of the consumer-driven insurance plans where there's a requirement for patients to have upfront spending, where there's a higher deductible, where they're going to actually be involved in making choices of where they go, and then also where their vitality and their well-being and their metrics will be part of the equation when their premium is calculated. So I think that the change of how policies are structured and patients actually purchasing their own policies may also cause some of that to be under a little better control.
Okay. Lee?
You know, right now I think that there's a bifurcation in the marketplace. In the commercial market, driven by employers who've been very sensitive to costs, there's more and more so-called skin in the game for their employees, whether it's picking their benefit plan or through co-pays and deductibles, deciding which physicians and hospitals to use. And we've certainly seen that in our organization. We're the second largest private employer in Illinois. Healthcare costs are probably the biggest driver of inflation on our cost side, so shame on us. We've got to deal with that. But we have about 45% of our workforce that is in an HMO benefit plan. There's over 95% retention year over year. It's a restricted network. They have wonderful benefits and good care, but the contribution from their paycheck is a lot less. And then in the last 2 years, we've created what we call the advocate-centered network, which is a much narrower network for employees who want to be in a so-called PPO benefit plan. The difference here is that if you want to go outside of Advocate, there's a 50% copay. That does get people's attention. Now, we're a broad network and we can treat everything, I think, except for we don't have a burn unit. And obviously, if you're burned and need to go to the burn unit at Loyola, that would be covered. But what I've come to appreciate is my wife sees a podiatrist once a year that's not in the network. So I get a bill for 50%. You know, I can afford that. But she knows that if she ever should need surgery, she's going to have to find another podiatrist because we're not going to pay the 50% out of network for a surgery center. And those conversations are going on everywhere except in Medicare. You know, across the country, over 30% of Medicare beneficiaries are in Medicare Advantage plans, which in essence are HMOs with narrow networks and extended benefits and real value. For whatever reason, and many of you could probably speculate better than me, in Chicago it's underpenetrated. It's under 15% with that. That's probably going to change. But in traditional Medicare with a supplement, once you've made your first couple of dollars out-of-pocket payment, you have first dollar coverage for the rest of the year, and if you don't like what Dr. Loeb says, you can go see Dr. Sachs and get a second opinion or a third opinion until somebody says you need the MRI that you think you need. And so it's not a surprise that when you look at healthcare costs in our country and compare us to other Western developed countries, say in Europe, when you look at the per capita costs by age, up until the late 50s, were almost identical. And then the U.S. costs just go off the chart. Until we solve the Medicare issue, it's unlikely that we're going to solve the global healthcare cost issue. So to get back to the ACO, I see it really as a hybrid. It's an attempt by the government and the Affordable Care Act to start to create better alignment for Medicare and bridge the gap between Medicare Advantage and Medicare fee-for-service. When I was involved in conversations early on some of the demonstrations, a lot of providers who've had success in different markets talked about narrow network, skinny down benefit plan design, et cetera, or even capitation. And Don Berwick and his colleagues just said that's the third rail of politics, and we can't go there right now. I think the ACO is going to be time limited, 3-4 years, and it's going to migrate into something more like a global budget. And the exchanges will probably bring out narrower networks. And just like any other commodity that people purchase, you're going to decide what the value proposition is. I may be comfortable buying a Chevy, and Barb may want to buy a Toyota or a Lexus, and she's going to spend more money. And that's where she sees value, and that's happening in healthcare.
Thanks. So what we're going to do in about a couple minutes is ask questions from the audience. We have two people who have the roving mics. After I ask the next question, which will hopefully be answered fairly succinctly, we'll open it up. Raise your hand. We'll try to do both sides. And identify yourself very briefly and ask a question, okay? Like Jeopardy, make sure it's in the form of a question, not a lengthy pontification on what you believe we should do to cure the ills of the U.S. healthcare system. Okay, so in order to give other people time to ask questions, make it short, brief, succinct. You get the picture. Okay, so while you're thinking of questions, one question I want the panelists to answer, just in one or two, short, bullets kind of thing. At the center of all of these efforts, ACOs, whatever, we have the concept of the patient-centered medical home. Now, whatever exactly that means for people, there's lots of definitions. But basically, the patient-centered medical home needs a primary care doctor, and if you're talking about Medicare, it's internal medicine. Geriatrics is out of the question because, if you can find a hen's tooth, you can find a geriatrician, right? So given that, and given that we're all of a sudden going to start dumping millions of people into the healthcare, that's a bad word, but moving millions of people who are formerly uninsured into the healthcare system, how are we going to solve the problem of primary care doctors? I mean, there just aren't enough. And let's avoid the question of physician extenders because that's too glib an answer. I want to make it difficult. So just one or two things that you think we can do. And starting with Steve, because you may want to expand your practice. You're going to have to find another internist to cover with you, for example. So it's relevant to everybody. So Steve, why don't you start?
Right, I think what the government and what insurance companies need to do is allow physicians to balance bill, physicians that are in primary care in particular. The primary care reimbursement has been decreased over the last few years, and the expenses in offices are going up. Now, you can have economies of scale, and that obviously helps, but and the internist may just ultimately be a loss leader in the system. But I think if you want to keep a variety of primary care physicians, you need to allow them economically to balance bill. So if a patient is, the insurance company pays $60, the patient has a choice whether they want to pay an additional sum on top of that. Right now, it's prohibited. The patient could have $5 billion, and if Medicare pays you $60, that's what you get. When you send labs out for a Medicare patient, the lab will ultimately make more money than the physician makes. So the physician decides which labs to order. The physician sends the labs out, interprets them, discusses it with the patient, and the physician will get a $60 visit. But the lab that the blood goes to ends up with a greater margin. So, that system, I think, needs to be corrected.
So you'd say better pay for cognitive services?
Yes.
To sum it up?
Yes.
Okay. Abel?
Jumbotron-led exercise classes.
Yeah, there you go.
I think prevention is key. I think we need.
Are you going to lead them?
I've thought about every time. For all primary care, you get out there and you see the same thing over and over every day.
How do you look in spandex? Not well.
Not good.
I'm sure that'll be
But I think we all
edited from the
realize that you have to
transcript.
focus on prevention. So I think there's interesting, novel, different payment programs that basically have employers will incentivize their patients to engage in more preventive care. I think that's good, and I think also taxes may be helpful to. And I shouldn't have said that, but taxes can help to, I think, drive down some unhealthy behaviors like smoking. That's been shown to work. So those would work.
Reduce demand.
Yeah, sure.
Okay, I'm gonna take a little chance here, but I would say patient engagement because just to expand on this is that 5,000 waking hours a day is what a person has, and they see even their primary care doctor a few hours out of the year. So out of that 5,000 hours, 4,998 hours you're taking care of yourself. So we have to figure out ways to decompress the system so that patients are doing more self-care and don't need the primary care doctor's time as much.
Self-care, patient engagement.
Right.
Okay, Lee.
The patient-centered medical home, while there's some controversy about true outcomes, the one thing I'm convinced it does, it enhances the efficiency of the physician. It creates team-based care, and it lets them use some of the modern tools. In this market, there's not reimbursement for e-visits, but in a capitated system, 1/3 of primary care visits can be done electronically using the Comcast infrastructure with that. But if you... I know who bought my breakfast.
Right.
But if you get paid for seeing patients face-to-face in your office, you do what clicks the meter. So we need to change the incentives. I think that there will be enough primary care physicians. They're going to need to change the way they work and be more efficient, and they'll be able to manage larger populations of patients.
Thanks. Okay, now it's up to you to keep the program going. Otherwise, I have to keep the program going. So why don't we, okay, over there, quick identification, succinct question.
Dan Schoenwald, practice administrator, comprehensive urologic care, Lake Barrington, Crystal Lake, Illinois. Patient satisfaction is becoming key to many of the programs, Medicare, Blue Cross, any of the clinical integrations at APP and that sort of thing. Yet, patient satisfaction is usually directly related to the amount of time that's spent, to the amount of tests that are done, to the amount of things that we do to the patient or do for the patient. How do we find that balance between the two? How do we find the balance for the patient who wants that MRI done but doesn't really need it and continues to go on, but they're going to give the physicians a bad satisfaction rating?
Steve, why don't you take that first? Because it's
that's
right
exactly,
up your alley.
Right, that's exactly what I've been saying. The problem is and if you continue along that line, you'll want to select out for well patients. There won't be anybody that wants to take care of the most critically ill, most difficult patient. Dr. Cushing was, a seminal neurosurgeon 100 years ago, and he used to have a 90% mortality because he would take on the most difficult patients. Now, in the way the organizations are going, he would have terrible satisfaction, and his numbers would look terrible on paper. So we have to have some way to put that all together.
Obviously the government and employers and payers have heightened the focus, and shame on me and my colleagues as physicians that we haven't made this a patient-centric system, and that's why satisfaction's so low. But in the aggregate, our patient satisfaction has gone up while we've improved the outcomes and reduced the costs. So they're not incompatible, but it takes a lot of work, and you need data, and you need to understand how to use that, and then train not just the physicians, but their support staff play a big role in it.
And I'd like to just make a quick comment. Having practiced all these years, I don't really believe patient satisfaction is based on how many MRIs you give them. I think patient satisfaction is based on how much you care about them, give them a good experience, and give them the outcome they want. So I would beg to differ. I think what we've done is we've thrown MRIs and scans and stuff at people because we didn't want to take the time to explain what was really wrong and what needed to be done. So I think we have to start thinking more in that direction and less in like a tangible test that we're going to give someone.
Over here.
Norm Brooks, Lee Brooks Consultants in Chicago. Recent CMS data demonstrates that 25% of all hospitalized patients wind up being readmitted within 30 days of discharge. And it's thought that, hypothesized that it's either patient noncompliance or medication mismatch and other expected or unexpected sequelae. CMS, the federal government, beginning this year, now reimburses physicians and surgeons for transitional care management, follow up with the patient aggressively by telephone and within 48 hours, and then visit within 7 days. The disappointment, because this empirically makes sense and is working.
We're in tight times, so your question is?
The question is, non-Medicare payers, including those who are supporting this program and those in this neighborhood, choose not to reimburse for this very important service that really can influence healthcare expenditures. What can we do collectively to change that paradigm to help influence reduction in readmissions and lower healthcare costs?
So I assume that you're talking about for example, non-capitated patients, because of course the incentives are built in. This would be more fee-for-service.
They may be built in, but the role of transitional care management with its identified phone call and visit applies to all patient cohorts.
Okay, let's open that up. I'd probably...
You know, I think it goes back to what some of us have said earlier about the importance of aligning incentives, because the readmissions is a great conflicting incentive. You know, the healthcare system gets paid for the defects, and when patients come back, hospitals and physicians get to bill more and got paid more. It's not as simple as paying for a couple of codes. You know, as we've dramatically reduced readmissions across Advocate, it takes a team, and it takes alignment, and it takes a lot of infrastructure with that. And you know, I think we all know deep down it's absolutely the right thing to do. Nobody wants to be readmitted. I like to say that when we discharge a patient, I've never seen anybody make a reservation to come back in within 30 days.
Thanks. Okay, question over there.
Yeah, I'm Russ Robertson. I'm the dean at Chicago Medical School. How are you all looking at the educational infrastructure? You know, we've got physicians that need to be trained, PAs, nurse practitioners. How are each of your organizations dealing with that topic?
Russ, we're dealing it with you. I think we have the same, you know, vision that we need to do team-based training. If our practitioners are going to function in teams when they're out in the real world, it makes sense that they be trained as a team. We need to train the next generation of clinicians to be adept at things like statistics and safety and technology, things that were absent from the curriculum when Joel and I were being trained. I think, you know, you're on the leading edge at Rosalind Franklin. The medical school curriculums and the postgraduate training have to be dramatically different if we're going to create the value that this country needs in the future.
Right. Abel, can you just mention very briefly maybe the IT curriculum at you're at Northwestern, so.
Yeah, I mean, I think that's certainly become something that a lot of the medical schools have taken into heart. I mean, part of systems-based care also is involving technology. I think people realize that we're not doing things on paper anymore, so if you want to understand sort of what's going on in your system, you have to understand the data. The good news is that the medical students coming up now and the residents coming up, all of them are very, very comfortable with technology. I think, you know, every time we teach a class and we ask for a show of hands, you know, in the past you'd ask for a show of hands and, you know, half the class or more didn't use an EMR. Now they all use an EMR. I think they expect it. In fact, they wouldn't go someplace that didn't have one. And so they are very comfortable with the idea about using data and, you know, working with data and analyzing data. I think that's a strength. I mean, the other thing that to keep in mind is that, you know, ACGME, I think, recently has a board certification in informatics. I think that the specialty organizations have also acknowledged that this is a growing field and something that needs to be acknowledged. And so this is the first year they'll offer it, and I think most will be taking that exam.
And as the dean of the Chicago Medical School, I mean, I would think it's vitally important to continue to teach the students not to lose the patient, you know, with all the complexity that we're seeing in healthcare. You know, and as students rotate through my office, one of the things I want them to understand is that you need to sometimes hold that patient's hand and look them in the eye and let the insurance company screw you, let the government squeeze you, but, you know, you're helping that individual patient. So that's my goal.
comments, Barb? or not?
Well, we also are doing similar things to what AVIC is doing. We have a number of residency programs within our system. We also have nursing advanced practice nurses that are educated through Res University, and we are trying to integrate them more into the front line of delivering care, although we're not supposed to use the word extender maybe. But I don't like the word extender anyway. They're primary caregivers to a lot of patients. So we're integrating them into our system. And also to mention, ACGME is now requiring residents to do performance improvement projects, and we're integrating them into a lot of our projects at the hospital so they understand what it means to actually improve the work, not just do the work.
Thank you. So there's a question over here.
Hi, my name is Ryan Grody. I work for Nurture by Steelcase. And as each of you talk about different elements and aspects of your organization, I'm curious about culture. And as you look at all the different things like lean and trying to demonstrate ROI, things that are in some cases new to the clinical community, what do you see as the biggest cultural challenge within your organizations, and how are you addressing it?
Could I answer that? Because we have done a system-wide lean initiative, we're in the middle of it. The really important part about that is the burnout and the stress that our frontline people are feeling in healthcare. As much as we physician leaders are feeling it, our staff is. And that has a very negative impact on the culture. By embracing breakthrough improvement and lean, we've re-engaged our frontline workers and not just doing the work, but improving the work. And I think that change in culture where their opinion counts is really very important to the culture of the organization. The other day, one of the nurses who was in a lean project where they rearranged the supply room. It sounds like a small thing to you, but it decreased the nurse's time looking for things by 2/3. And she was proudly showing me the supply room and how it was ranked in according to what she needed. So we need to change our culture where we re-engage those people doing the work, and that will help drive our improvements.
Over here.
Hi, John Thomas from Modern Healthcare. My dad's a surgeon and former professor of surgery. He actually retires tomorrow. Yeah. And we've sort of been, talking about his career. My father's very in favor of informing patients, but in the conversations that we've been having over the last week or so, he's very dubious of the purported benefits of informed consent overall. And I was wondering what your feelings about that are.
Abel,
I think
how about that?
I guess I would disagree with that. I think there's been an interesting article, I think it was published a few months ago, called the Open Notes Project. And that Open Notes Project, essentially what they did is they made available the progress notes of the providers to their patients. And what's interesting is that the outcomes actually improved in those patients, in large part because the patients were able to see how important the provider thought the actions or the plan was, the assessment and plan was. And so the providers or the patients were more likely to follow through with those action plans. I think certainly your point is well taken, though. I think that it's a shift. I think it's a big shift in how we would approach care. But I don't think that it's. I can imagine instances where you would maybe not want to share information, whether it be around mental health issues, for example, back with the patient. But I do think in the vast majority of cases, I think opening it up, I think would actually likely lead to a better outcomes, and that's what's been shown so far.
Maybe if I can use my prerogative to chime in. Both the HIPAA and informed consent forms are needlessly complex, needlessly. All the language is not required by law, and we have laws now that require insurance companies to make their policies understandable by individuals. We probably ought to do the same thing for informed consent and HIPAA consents as well.
I'd like to add a quick comment on our lean project. We had actually a very highly technological informed consent software that was costing us like $70,000 to use and taking nurses 19 minutes a pop to figure out what the patient was consented for. And we actually simplified it to a common sense form that it was complying with Joint Commission requirements, and it cut down their time to put it together from 19 minutes to 1 minute. So sometimes maybe I'm not a lawyer either, but maybe the legal system has turned us into knots trying to put every permutation on there, and there's a lot of waste in that as well as misunderstanding. So.
Right, so we have time for 2 more questions, one here. Yeah.
Good morning, John Fitchwell with Athena Health. My question is something we've been talking about a lot, back to payment. But my question's simple. Why can't a model similar to Dr. DeAngelis or that Ben Carson spoke about at the presidential prayer breakfast, why can't that work? Why can't a direct payment model, patient to provider, work in our system?
Well, if I may take that question, I think you could do that, and I think you'd still have payment. So my suggestion would be the insurance companies in a demographic area or in a geographic area would say an office visit for DeAngelis, is usual and customary is $100. If DeAngelis wants to charge $150, the patient has to decide whether I'm worth it or not. If the $100 is what the insurance company or Medicare gives them, there'll be a lot of young, good physicians that would be coming out that would say that that's a wonderful way to build their practice and continue to provide it. So I think you can do it, but I think there's a lot of forces against doing that, including the government and insurance companies.
Other comments? Okay. Last question.
Good morning. Tayabe Shamarani with Unified Physicians Network, and as well as the healthcare cohort at Loyola. I appreciate the support of independent practice here on the panel today. I think it's wonderful to have an integrated panel. My question is directed to Dr. Ko. What would you say an independent association of physicians who have multiple EMRs, where should they look in terms of putting together a health information exchange? Where should we go today?
So that's actually been sort of a neglected space. So if you look at HIEs, they tend to always focus on the large systems because that's basically where all the big data is, but that's not really the case. If you string together 100 small practices, you've got a patient population that's as large as any, or as large as a system unto itself. It's actually interesting, the state of Illinois has taken on, and we are part of this project called the White Space Proposal, which is to try to tie together small practice together in an HIE and across different platforms and small practices like 1 or 2Zs or 4 or 5 doc practices. It turns out that there are a lot of groups interested in this space, whether they be startups or existing established technology firms that want to get in this space and see the value. They see that 65–70% of visits in the country still are in small practices. You can't ignore that. So I think right now I would say it's not solved. I think it's still a work in progress, but there are initiatives locally going on. And also if we look to see the national vendor scene, there are also larger national networks starting too.
Okay, thank you. So just in conclusion, the first person I'd like to thank is Amy Shivers, who is really the person responsible for putting this all together. Parenthesis, no kidding. Okay, she really did all the legwork and deserves a lot of the credit. Thank you to our panel. That was really great. Thank you all for coming. And thank you to our sponsors as well. And thank you to Crain Chicago Business for hosting this. And hope to see you next year. Amy, do you have any final words? Okay. Please.
Let's have one more round of applause for our panelists, Steve, Abel, Barbara, and Lee, and our fantastic moderator, Joel, and to our sponsors who made today possible, Comcast Business, Humana, Hired My Way, and Loyola. Thank you so much. Enjoy the rest of the day.